Thank you, Dr. Nageshwar Rao, Professor Krishnam Raju, Dr. Kondal Rao, and team Telangana CSI for giving me the great honor of giving this oration. Professor Rajendra Tandon was considered to be the fountainhead of pediatric cardiology of the country. He was the first person to emit out the first 6 pediatric cardiologists, who subsequently trained many more. When he retired in the year 1991 from All India Institute of Medical Sciences, the structural interventions that were practiced during those days were balloon pulmonary valvotomy, aortic valvotomy, septostomies, and coarctation dilatation. But a great deal of diagnosis of pediatric cardiology and the foundations of hemodynamics was laid by him and his colleagues in catheter hemodynamics and angiography, which guided a lot of surgical and management decisions. Over the subsequent last 2 decades, structural interventions has grown a lot. Huge number of devices for closure of various defects, stents, balloons, coils, occluders. Tremendous boom in the last 10 years on transcatheter valve therapy. Surgical pseudoaneurysms, paravalvular leaks, dissections, aneurysms, fistulas, perforating membranes, recanalizing closed vessels, alcohol ablations, covered stents. This adds tremendous responsibility for all of us to understand the hemodynamics, because each and every structural intervention is going to be guided by hemodynamics. So the topic, understanding hemodynamics in the current era of structural heart interventions. I would say back to the basics laid down by Dr. Tandon before 1991. Lots of critical decisions on structural heart interventions are taken only based on hemodynamics. Every regurgitation, every stenosis, every shunt is classified as mild, moderate, severe, more than 2:1, less than 2:1, right to left, left right. Each one is dependent only on hemodynamics. It's largely measured either in the cath lab or on echocardiography. Mostly in structural interventions, these measurements are in the cath lab. So this is what we are going to highlight now. Aortic valve interventions are increasingly becoming common in these last 10 years. It's a common clinical problem defined as a valve area index of less than 0.6, peak AS gradient of more than 64, and mean AS gradient of more than 40. If this patient is symptomatic with syncope or dyspnea or angina, he has got a very predictable poor outcome within a fixed phase of his life. And so, every symptomatic severe aortic stenosis gets carefully assessed to find out what is a valve area, what is a peak and mean gradient. Come to a clinical situation. A 71-year-old male, systolic murmur with aortic stenosis on echo. He progresses in 2 years to class 2 dyspnea. We know that from now onwards the clock has started ticking and we need to interfere. He gets occasional pre-syncope. The hemodynamics warrant AVR. His normal ejection fraction, his age is acceptable. He becomes an intermediate risk candidate for a TAVR. An aortic root angiogram is done prior to a TAVR, which shows a calcified valve with severe aortic stenosis, and now comes the importance of what is the hemodynamics. When we simultaneously overlap a left ventricle and aortic tracing, we get a number which is the instantaneous gradient. At a given particular point, what is the maximum gradient, and which is measured on the Doppler. And this here is 64, almost matches to the echo gradient of 64, warranting that to be severe. So then there is a peak-to-peak gradient that is often recorded in the cath lab, the peak of aortic pressures and the peak of LV pressures. And then the area under the curve is the mean gradient. So his gradients are 40 millimeters of mercury. So he gets a TAVR, and following the TAVR, there is no aortic regurgitation. Look at the trace. He has got a matching LV and aortic pressure curve, so there is no residual gradient. It's not just looking at only those gradients. Concentrate on the dicrotic notch. It is located somewhere in the middle of the aortic curve. This is considered to be a very satisfactory outcome. The reason being, I'll show a poor result TAVR and show what is the hemodynamic show. A 74-year-old senile calcific aortic stenosis with again a normal left ventricular function gets a TAVR. Immediate post TAVR, the hemodynamics, systolic pressures are about 105, the dicrotic notch is quite low, diastolic pressures are quite low, touching 40. Relatively mild hypotension, started off with pressures of 140. So what is the problem? A sapien valve is in place, there is an annular rupture, this annular rupture is now leaking from the aorta into the left ventricle. Nowadays in the era of minimalistic TAVR, not too many imaging is done. There is no on-site transesophageal echocardiogram. Very often you have to go for just a simple transthoracic and identify. And in an extremely elderly, fragile lady, getting appropriate echo views are tougher. But what prompted that this patient may be sick was that low aortic diastolic pressure and a low dicrotic notch. So now you try to address this leak. This is the aortic annular rupture that is rupturing into the right ventricle. You plug it with a duct occluder device, and what is changing? Previously, the aortic diastolic pressure is quite at a low level. Immediately after the procedure, actually the aortic diastolic moves up. Look at the aortic systolic pressure. It's walking around the 90 to 100 prior to the procedure. It improves to 140 to 145 post-leak closure. So a tremendous amount of information is given by the hemodynamic tracers, which is going to tell, is the patient stable enough, not just simple gradients. Coarctation of aorta is another area where Professor Raj Tandon used to put a lot of stress on clinical examinations and hemodynamics, and his photograph is being shown in multiple forums because this is going to be serving as the sort of the stimulus for all the young cardiologists to concentrate on basic clinical examination and not to go with superior investigations like echocardiography. Coarctation of aorta is associated with a wide pulse pressure above and a narrow pulse pressure below, and this narrow pulse pressure is responsible for weak femoral pulses. If you look at the mean pressures, it will not be terribly low, but it is the low pulse volume in the femoral arteries that makes it feeble. The bounding pulse in the upper limbs are created by the very wide pulse pressure. The definition of coarctation is more than 20 millimeters of mercury at rest or more than 50 millimeters at exercise. There are various reasons why coarctation can have lower gradients but still remain significant, either in the presence of left ventricular dysfunction. This is the same situation in newborns where some of them will have severe pulmonary hypertension, persistent pulmonary hypertension. So there is a precapillary level spasm of the pulmonary arteries which acts like something like a second mitral stenosis in the front and does not allow a sufficient amount of LV inflow, LV stroke volume, and so the gradients may be low. Whenever they have a proximal mitral stenosis as in Schoen syndrome or a proximal aortic stenosis as a bicuspid aortic valve, they may have low gradient coarctation. Large PDR collaterals may mask. If a patient is on anesthesia, you may have a patient who was having more than 20 or 30 clinically, but you put on table and you give anesthesia, the patient may not have any gradient. Shock state, post-vasodilator drugs, or significant aortic regurgitations are other reasons. It will be interesting to understand what determines the gradient in a coarctation. As was any gradient is dependent on the blood that is flowing through a particular structure. So that is dependent on cardiac output. So lower the cardiac output, there will be lower gradient. Depends on the heart rate. Lower the heart rate, there will be lower gradient. Extensive collateral circulation and a large PDA ampulla may obliterate the gradient. Length and shape of the obstruction. A very discrete coarctation may give a very high gradient, whereas a long tubular transverse arch narrowing may get less gradient. Baroreceptor function, which is intrinsically decided by each and every patient. There will be a same type of coarctation in two 30-year-old persons, one with severe hypertension, another with literally normotensive, because each person's baroreceptor function is different. Arterial wall compliance. A patient who is having a bicuspid aortic valve with a hugely dilated ascending aorta may not have a sufficient gradient, whereas another patient who is having quite a narrow aorta may have a very high gradient. Vessel wall distensibility is another feature. Now moving away to the third area of LVOT narrowing, subvalvular LVOT narrowing versus valvular LVOT narrowing. I'm going to show a clinical example. A 22-year-old girl with a hypertrophic cardiomyopathy who presents with exercise-induced syncope, LVOT narrowing with moderate mitral regurgitation that is seen. Look at the echocardiography, hypertrophied left ventricle, SAM of the anterior mitral leaflet. This results in a moderate mitral regurgitation. When you look at the short axis, you find that the anterior mitral leaflet has got a lot of attachments of the chordae to the septum. So, if this patient has to go for a surgical myectomy, we have to cut these chordae, and if we cut these chordae, she will end up in MVR, which is one of the options in a 22-year-old. Now you take this patient into the cath lab. Before showing the patient's cath lab traces, I will show what is a post-ectopic potentiation in a normal valvular aortic stenosis. In a valvular aortic stenosis, in a post-ectopic beat, we have an increase of the LV pressures. So the pulse pressure before and the pulse pressure in the post-ectopic beat will show a wider pulse pressure. On the contrary, in hypertrophic cardiomyopathy, post-ectopic beat will have a lower pulse pressure, and this is what is called as the Brocken-Braunwald effect. Now we come to the index patient. We have the left ventricle. The left ventricle is showing a late systolic peaking, which indicates that this aortic stenosis is quite severe, and the aortic trace is showing a spike and dome. That means rapid ejection in the earlier part of systole, but in later part of the systole, the Venturi effect is preventing a significant systolic hump. And so this gives the bifid pulse. Look at the trace. What is dynamic LVOTO? As you keep on observing the patient, the gradient varies from time to time. What is 50 here and what is 70 here? When it is 70, you see that the lateral dome is very, very, very short. When it is 50, the lateral dome is quite at a height. So the gradient is quite variable. This patient gets a couple of ectopics, and when there are a couple of ectopics, the Brocken-Braunwald phenomenon gets added up, then the pulse pressure becomes extremely low. This is 2 ectopics in this trace. Take it to about 5-6 ectopics, the patient literally goes into a syncope because there is no pulse volume at all here. The systolic pressure is touching 40s. So now look at what is the reason for the MR. There is an MR. Left atrium is left atrium pressure is shown here. There is a prominent V wave indicating the severity of MR. As the LVOTO increases and the dome of the aortic trace is reducing progressively, MR keeps on increasing, indicating the systolic anterior motion of the mitral leaflet, which is causing the MR, is directly proportional to the amount of LVOT obstruction. More the obstruction, more the MR. Which means, if we obliterate the LVOT obstruction, we are going to obliterate this MR. So this patient gets an alcohol ablation. Immediate post-ablation, absolute reduction in the LV to aortic gradients. Keep watching. Are we doing good for this LV or not? LV end diastolic pressure falls substantially to 12. Is it transmitted on the mitral valve? Mitral traces fall down to 8. So tremendous improvement in the hemodynamics because the pathology has been identified to be purely due to hypercontractile septum. So the baseline ECG prior to the condition shows left ventricular hypertrophy. So have we created just a transient stunning? Tomorrow morning the patient is going to have all the severe gradients again. This is the post-procedure true right bundle branch block with a high septal infarct showing ST elevations. So every decision in this patient was guided by hemodynamics. A recurrent pre-syncope in a patient who is having hypertrophic cardiomyopathy but no documented VTVF, somebody will say ICD has to be done, but ICD was not done. Gradients increase dynamically from time to time with associated hypotension. So this exercise-induced gradient or increase in the LVOT obstruction was identified to be the precise reason for the pre-syncope. The caudal attachment to the septum forces MVR. We did not want to do an MVR in a young lady. MR was completely dynamic. So the confidence that relief of LVOT resection, LVOT obliteration by alcohol is going to obliterate the MR also proved correct. Coming to mitral valve intervention, I used to tell my fellows, whenever you have a patient with mitral stenosis with a high JVP, if you put on table and take the RA pressure, and if you are having high A waves, that means it is due to PAH and RV hypertrophy. This patient will improve after BMV. On the contrary, if you are having an elevated JVP with a prominent CV waves and Y descent, this is organic tricuspid regurgitation. This patient's right heart failure will not improve after BMV. You will continue to need diuretics. Coming to left atrial pressure trace, look at the V waves. V is taller than the A. Whenever V is taller than the A, there are two reasons. One is presence of mitral regurgitation. Second is very poor left atrial compliance. VY descent is slow, it is not fast, so it is taking a lot of time. That means this is due to poor LA compliance and tight mitral stenosis, and this is not due to MR. So in such a patient, you do the balloon mitral valvotomy, post-procedure, the LA pressure reduces from 34 to 24, acceptable result, but because the LA compliance is low, they do not fall down to 10 and 12 as in other patients who will have a good LA compliance. But we have to be careful. Whenever the patient is showing such a tall V wave indicating poor LA compliance, even if you create a moderate mitral regurgitation, another patient who is having a steep VY descent now, even a moderate MR will be catastrophic in these patients. So identifying A wave and V wave in the left atrium is mandatory before a mitral procedure. Transcatheter mitral valve therapy, a degenerating mitral valve prosthesis, you do the preoperative hemodynamics, there is combination of mitral stenosis, there is a wide gradient here, tall V waves indicating mitral regurgitation, a combination of MS and MR, a transcatheter TMVR is being performed here, post-procedure, excellent result on transesophageal echo, but is it transmitted on hemodynamics? Look at the hemodynamics, LA pressure has not reduced substantially. There is a steep VY descent, that means there is a mitral valve leak. Carefully look at the LA pressure trace. There is a steep VY descent. So there is a paravalvular leak. Look at the echocardiogram. There are actually paravalvular leaks both on anterior and posterior end. So a larger balloon inflation was given to the same valve and that resulted in obliteration. So very careful attention to finer hemodynamics is extremely important. Pulmonary valve implantation. A patient who is getting a melody valve implantation, a melody valve is fully inflated. Post procedure, you take the hemodynamics, RV pressure and PA pressures both look similar. That means pulmonary artery is ventricularized. If that means pulmonary regurgitation has not been corrected. Look at the angiogram. In spite of the melody valve, there is a severe PR. That means the valve leaflets are not functioning at all. This has been identified prior by our catheter hemodynamics itself. Put in a second valve and following the second valve, now look at the trace. The trace now shows the PA diastolic is staying above. So there is a diastolic gradient. Every aortic valve and pulmonary valve should have a good diastolic gradient like this. There should not be a ventricularization at all. Now repeat the pulmonary valve angiogram. There is a complete closure of the pulmonary valve. We come to almost the last part, hemodynamics in a left-right shunt device closure. This is where Dr. Tandon used to inform a lot of caution before closing defects which are like sort of ambiguous. In ASD device, we should realize that restrictive LV physiology and severe pulmonary hypertension are dangerous diseases. Restrictive LV physiology is identified by high end diastolic pressures, this is around 25 to 28, and in these patients, temporary balloon occlusion can be done to see how much the LVED goes up. From a level of 12, it increases to 25, and that indicates that this patient is not going to tolerate a complete ASD closure. You may have to adopt some fenestrated ASD devices. Same way, if a patient is having pulmonary hypertension, this is a PA systolic of 68 millimeters. Any pulmonary artery pressure of more than 60, you should try to exclude a fixed PAH. But in table, sometimes it may be difficult to exclude instantaneously because we have to wait for a lot of oximetry. And as you are waiting for the oximetry, you can do a test balloon occlusion. This is a test balloon occlusion of a patient who is having nearly 60 PA pressures. You keep on occluding for a long period. Slowly the PA pressures come down without a fall in the aortic pressure. That means the PA is partially going to be flow dependent. Now, is it just an artifact? deflate the balloon. Slowly the PA pressure goes up. So this sort of hemodynamics in the cath lab is going to tell us a lot of confidence for us to close an ASD which is borderline. PDA device, similar, hypertensive PDA. Aorta and PA pressures are sort of matching. When you give oxygen, the aortic pressure goes higher on the systole because aortic stroke volume increases. The QP by QS, higher the QP, it is the aortic valve that takes the higher QP in a PDA. So aortic stroke volume increases, so the aortic pressure increases. Do a test balloon occlusion, there is a good separation between aorta and PA, and in these patients, it is a good to close the PDAs. But we need to remember, there are a lot of reversible factors in elevation of a PVRI. There can be bronchopneumonia, bronchial asthma, hypoventilation. I'll show an example. A large PDA in a 3-month-old baby who got on to bronchopneumonia and ventilator. Now, whenever the ventilator was not functioning well, there is a complete right to left shunt. You see here? But when the ventilator is optimized, there is a left-right shunt. So, we have to remember that it is highly variable depending on transient conditions regarding ventilation. The same patient in the cath lab, RV pressures and aortic pressures are almost similar, indicating severe PA. When you are ventilating the child properly, aortic pressure goes up, pulmonary artery pressure remains the same. So, indicating that this patient is operable. You close this PA with a device, but in the post-procedural period, you find that the child hypoventilates and the device spills into the descending aorta, the reason being the PA pressure transiently went up, thereby causing reverse embolization. So how do you manage? This is a patient who had a bronchopneumonia because of a large PDA and a large shunt. So the decision to close was correct, but the only thing, we are not able to transiently control the PVR. So you snare the device, pull it back to its position, optimize the ventilation. Now with the ventilation, optimization results in progressive reduction of the PA pressure, then you release the device stays in place, and you continue to maintain this patient's ventilation in such a way that the PA pressure continues to stay low. The rules of closing a shunt in an adult, don't take up ASDs with restrictive LV or fixed PAH, and we need to pay an attention on the operability. The last part, pulmonary hypertension is largely a disease which is medical. However, structural interventions are feasible, which are either balloon septostomy or pot shunt. Basic difference between a balloon septostomy and a pot shunt: a balloon septostomy fills the LA and LV better because of better preload, so syncope is avoided. And same way, RV decompression will push the RV from the declining part of the Frank-Starling slot to the summit of the Frank-Starling slot, whereas pot shunt works only when there is a suprasystemic PA pressure. This is an example of a suprasystemic pulmonary artery pressure with a distended right ventricle. PA pressure is significantly higher than the aortic pressure. You do an aortic angiogram, there is a small ductal ampulla, you recanalize that, put a large 12 millimeter stent, and following the stent, you look at the hemodynamics. The PA pressure has substantially fallen, which results in improvement of the RV function, but LV remains underfilled because the preload is less for the LV. So what we went through a series of conditions where different forms of LVOT obstructions, mitral valve interventions, pulmonary valve intervention, shunt lesions, pulmonary hypertension, where hemodynamics played significant role in decision making on table. A large number of structural interventions are carried out now. The safety of these procedures and the outcome of these procedures will largely depend only on the hemodynamics. And so it is very, very important for us to understand the hemodynamics for a successful procedure, and not paying attention to these traces will make a safe intervention into an extremely hazardous intervention. Thank you. Thanks for the opportunity given to me.